Hey, I'm Dr. Durrani.
And I'm Dr. Kendall Moore, and welcome to Cuts and Consults.
And we are super excited to be joined by my friend, Dr. Eric Singhi, board-certified oncologist. Welcome to the show.
Thanks for having me. Excited to be here.
Yes, and he is a good social media follow for everything that is oncology and lung cancer related. How'd you get into the Pitt? First question.
Yeah, so actually there was a lot of buzz about the Pitt just in general from the medical community. I also work with a lot of trainees at my institution, and so just talking about seeing what real life medicine looks like on the big screen was really exciting to be able to share that with the colleagues that I work with the trainees that I work with, but then also people that aren't in the medical field, right? Like have them see a little bit of what our life is like when we go to the hospital, when we go to clinic. So that's how I got into it.
Yeah, nice. And you've been watching since season one.
I have. Yeah. I'm a diehard fan. Watch every week.
Yeah. What when it comes to like your med school days or residency, you remember some of your ER rotations at all?
Oh man, I try to block those out. I don't know how you guys do it. I have so much respect for you guys because I'm the kind of person that likes to stop, really spend my time, just really think about the labs, the imaging before I come up with my plan. And so I learned very quickly when I was in medical school that the ER life, ICU life is not for me. I really like to have all the data, all the evidence. You know, I talk about evidence-based trials and studies and phase 3 studies all the time on my social media. I love having all of that, having that luxury of time before I make my decision. And so I have so much respect for you guys where you have to think on your feet. You have to think quickly.
Yeah.
For sure, man. Thanks for coming on the show.
Yeah.
So what have been your takes season 2? What are you liking about it? Anything you don't like about it?
Yeah, I mean, I love how, honestly, we were talking about this a little bit earlier too, right? Where we're just getting to see a lot more breadth of medicine, not just the clinical decision making, but a lot of things behind the scenes, right? We'll talk and unpack some of this from financial toxicity, from some of the other sort of care team members that are involved beyond physicians, beyond nurses, some of them that aren't necessarily licensed, but still really important, right? So I enjoy that. I've also really enjoyed from the character perspective, the growth that we're seeing from the interns who are now senior residents, from the medical students who are now, higher level medical students. And it's nice to see and sort of follow along with their journey. And I kind of remember, I try and put myself in my shoes of what I was like as a M2, M3, as an intern. It's nice to see that.
Yeah, it's crazy. You even think back to residency and like the first year resident, you're like, it's impossible I'm going to get to operate like my senior. And then somehow 3 years go by really, really quick. And you're like, oh, wow, now I'm that person.
Yeah, it's wild. I very fondly remember my residency training, my fellowship training, but at the same time, it just like flew by, right? It's wild.
Yeah. I don't think I've ever asked you this. So you do a lot of good educational social media content, and you do a lot of dancing in it. So have you been a dancer ever since you were a kid? Or tell me about how those two came together.
So I'm Indian, and so my Indian heritage, Bollywood dancing, Bhangra dancing is really popular. It's a way that we express our culture, and I would do a lot of those things growing up. And so fast forward to college, I actually was doing some dancing in college as well too. And then it just all stopped in medical school. You get in the grind, you get busy, you got your step exams, rotations, all that. So it just took a pause for a while. And then it was all about the science, and it was all about the data, and it was all about the facts, right? And I needed to find some outlet to express myself, to have that creativity. And it was just kind of happened fortuitously, if you will. Same with social media. We can talk more about that. But started to find different ways to express myself, to sort of decompress, to avoid burnout, and then it caught on. And so I continue to sort of mix it up on social media, from dances to fireside chats to me in my car, you name it. People just don't know what to expect, and they're here for it.
Yeah.
It's a good thing. Our last guest was telling us dancing decreases the chance for dementia. So
okay, well, good. I need that.
our last guest was telling us that you read a study about it.
Wow.
Yeah, and that's one thing I'm not. I don't know how to dance. I don't have like that gene. Yeah. What about you? Are you a dancer or no?
I do the standard dance, side to side.
Okay, all right.
Wherever go
catch you on the wedding dance floor.
Wedding parties, I'll do that. But yeah, that's about it.
Nice. But what about social media? How using social media as a medical education tool? When did you first start thinking about that? And a lot of people are kind of nervous about entering that space. Tell me about that.
I love listening to everyone's journey about getting onto social media. Honestly, mine was not really planned or thought out. Education has always been a passion of mine, and I feel like as physicians, as professionals in the medical field, education is a really important part of what we do, right? We treat patients, we treat their families, but also educating, disseminating correct information, and empowering patients and their families to be able to really become partners in their care has always been important to me. And I remember I was in my fellowship training, really starting off my fellowship training for oncology, and then COVID happened. And we had to learn like really quickly what to do for our patients, how to protect ourselves, and find information that was credible, right? There's a lot of misinformation, a lot of disinformation online. And I really leaned in during that time. I leaned into social media trying to figure out the facts to help my patients, to help my colleagues, to help myself. And it was all factual. It was a lot of just me learning, honestly. And then I realized once I got more involved with it that there's this huge gap of patient education, really credible information in oncology. I felt that there was this huge vulnerable patient population that was eager to get information. And so they were picking up a lot of this misinformation, disinformation. And there weren't a lot of medical professionals that were there giving that type of information in very digestible, bite-sized ways. And so that's sort of how I got into it.
Yeah, yeah. We're trying to convince this guy to be more on social media too.
It would be amazing. You got to do it.
Yeah.
We've been talking about it. I'm just kind of like just laid back private, but I appreciate you guys doing it. Like you said, it's a lot of misinformation. A lot of people come in, things I've heard is not verified by, physicians. And so to have you guys on there doing that is really important.
What, a lot of times, for maybe a non-medical audience, oncology seems like a scary word, but also seems like a broad word. So your day-to-day, tell us what that looks like.
Yeah, so medical oncology, what do I do? So I am someone who is really helping a patient and their family navigate through their cancer care journey from the beginning all the way to the end, to be honest. And what I do is I give medical drugs to help fight and treat cancer. And I'm one team member. Often there's other team members that are involved, surgeons, right? If the cancer can be taken out with surgical resection, radiation doctors as well too, if radiation can be used. It's all about really teamwork in cancer care. And what I think is really important to understand in terms of oncology and cancer care is that not all people that have the same cancer diagnosis will experience it the same way. And we are truly personalizing our treatment plans for patients with cancer. And so personalized medicine, personalized plans, truly treating your cancer, not just cancer, has become a very central theme in what I do.
Yeah. And, you focus on the lungs. Is that correct? Yeah. And so is that a different fellowship if you become like a specialist with the kidneys and other organs, or explain the difference between that?
Yeah. So I'm a thoracic oncologist, which means I treat really any cancers that start in the thoracic cavity, particularly the chest, but also the lining of the lung, other areas, kind of like the thymus, for example, too. And you go through your general medical oncology fellowship. It's often sometimes combined with hematology, so blood disorders, blood cancers as well. That's usually about 3 years. And then there can be additional fellowships that you can do afterwards. They're not mandated, but there are some that you can do afterwards, and they're very subspecialized, like in thoracic oncology and renal cell carcinoma, you name it, right? You don't necessarily have to do those, but what's also nice in the fellowship program that I did is our last year is really open to what we want to do. So research or really leaning in on a subspecialty, and that's what I did. Mm-hmm. So I was a chief fellow that year. I really leaned in on only seeing patients with thoracic malignancies, lung cancer, spending time all day, every day in clinics, only seeing patients with lung cancer, and then doing research just focused in that space.
Yeah.
It's crazy, man, because we're all doctors, though, but you don't really know what's out there. So many things you can specialize in, as far as different specialties, subspecialties inside of oncology. Even I have no clue about that.
Yeah, that's why I asked. Sometimes it's you have to be a little vulnerable. People just expect, oh, you're a doctor, you know every specialty.
Yeah.
It's way. No, I know oncology deals with cancer, but I know you do lungs. Is that like a fellowship? Is that something you kind of slide into? Is that and same with ortho, right? You're like, I'm going to refer to this ortho, but they're like a foot and ankle specialist. Could they do a shoulder? No, probably, maybe.
Yeah, that's actually a really good point.
Yeah.
So do you only do thoracic, or do you ever do any other type of cancer? Or do you specifically 100% thoracic at the moment?
It's probably about 95% lung cancer, thoracic oncology. I do see a little bit of head and neck cancers as well, but it's the minority of my practice.
Gotcha.
This isn't the reason we're here today, but just kind of broadly speaking about the space, would you say in terms of innovation, new treatments, things happening, is it something that's happening really fast, kind of moderate rate, not really happening? Would love to just kind of get your insights on that.
Oh man, yeah, I am so privileged to be able to take care of patients with lung cancer today as of 2026. There was actually just an FDA approval yesterday. That's how fast things are moving. So like I said, I work with a lot of trainees at my institution, and almost every month they rotate through and I get to say, hey, listen, we have this updated data from this trial and this led to an FDA approval. It's almost like every month, every other month in lung cancer. So there's absolutely hope. The science is moving incredibly fast. And lung cancer is truly this poster child of personalized medicine, where we're really trying to understand exactly what type of lung cancer the patient has and then matching them to a very targeted, precise regimen of therapy.
Yeah. That's really cool to hear because, as all of us were coming up, you hear about personalized medicine, but now you're starting to see some of the actual implementations of that, especially in the cancer space. So that's really cool. Awesome. We ready to jump into some clips?
I'm
Take a look
excited.
at them.
Awesome. Well, this is our first one. I believe this is your clip.
Okay.
Yeah, let's do it.
I was looking for you.
Well, you found me.
The x-ray came back on the lady with the cough. Weird infiltrate. Have you seen it yet?
I've been trying to catch up on my charting.
Right here.
Yep. Stringy right lower lobe.
It looks like aspiration pneumonia. Think about it. How do oral and gastric fluids end up in lungs?
Dysphagia, swallowing disorders, but she's not an old person choking on their food.
Right, and there's protracted vomiting.
Okay, maybe recent gastroenteritis, food poisoning.
Yeah, or an eating disorder.
Think she's bulimic?
I mean, she's fixated on working out. Check the enamel behind her front incisors. If it's not in the differential, it won't be in the diagnosis. You know that? Yeah, you know.
Oh man. So tell us why you picked this clip.
Honestly, for that last line that Mel just delivered, right? If
Yeah.
it's not in the differential, it won't be in the diagnosis.
Yeah.
You guys are also emergency medicine physicians. I'm internal medicine trained. And so the differential diagnosis is huge for us, right? I remember being pimped by attendings about the differential diagnosis. We'd have to write it beautifully in our internal medicine notes. That's why our rounds take so long as internal medicine residents too, because we love to talk about all the differential diagnoses. And I think that's really important though, right? One, we are very susceptible as just medical physicians to have this anchoring bias, right? Where, you just sort of make your short list and then you just stay in that. And then you don't think about the zebras, right? And potentially the other diagnoses that the patient could truly have. And then it leads to premature closure where you just stop short of immediately thinking beyond an easy diagnosis, if you will. So that's why that really resonated with me, is because it takes a lot of vulnerability as well, too, to put out a diagnosis sometimes, especially to your colleagues, to your peers, to your seniors. And so I really appreciate that she did that.
Yeah.
Yeah, for sure, man. Thinking outside the box for sure. I mean, in ER, you never know what you're going to get. It's always like I call it like you're walking through a landmine with like clown shoes on sometimes. Like you're just waiting to step on something because you have the weirdest diagnosis. And so we do have the tendency to like anchor on certain things. Everything comes in, chest pain, you're looking for heart attacks, but it's also be dissection piece. You just got to make sure you keep your differential wide and keep expanding on it and work everything up.
Yeah, and we talked about during one of our previous episodes anchoring and how easy it is to do that, because you see something and it looks like something and a few pieces of evidence kind of support that and you're like, okay, case closed. And it's so easy to do that, especially when you have a full waiting room or you're rounding and you have 20 other patients to round on. You're like, it'd be easy to just do that, but that's how you miss things and that's how you get bad patient outcomes. And so, to any medical students, residents, anyone listening, I know it can be gruesome at times and tiring and rounds can last forever, but it's very, very important. And it's one of those things where when I was a trainee, obviously everyone's like, oh man, rounds is going to take 6 hours because we're going to talk about all this stuff. But like now, to be honest, like when I get that, one-off case that's not clear cut and I'm having to like go beyond the PE, ACS kind of thing for chest pain, I'm like, oh, what else could this be? I find joy in that because like everything else, it's like bread and butter. You're going through it and it is the thing that you think it is in front of you. And so it is sometimes fun to kind of go on those like mysterious like journeys and try to figure some things out.
Yeah, it's not just med students either. It's like even seasons attendings. Like you keep seeing things over and over and over. Like, okay, I've seen this a million times. This is what it is, and you may not, go that deep into it, and you can miss stuff. Especially if you've been out like 10, 15 years. Not everybody reads all the time. I know you read a lot of studies. Sometimes people. I mean, it's a good thing you do because a lot of people like don't keep reading, and you keep seeing this stuff over and over, and you can anchor on one thing as well and miss it.
Yeah.
I'll put in one more plug just personally. So I focus on young onset lung cancer. So the majority of my patients in my clinic are under the age of 50. And this incidence is rising. So right now it's about 10% of patients being diagnosed with lung cancer today are going to be under the age of 50. And it's painful to see these patients being dismissed or having delayed diagnoses because of something like an anchoring bias, right? Oh, you're too young to get lung cancer. You're too young to have cancer. And so I think this really resonated with me as well, too, from that standpoint, just to say we've got to move beyond that anchoring bias. We've got to move beyond that premature closure to give patients really the benefit of the doubt to really understand and work them up if they're having recurrent symptoms, if they're having symptoms that have yet not been diagnosed correctly, right?
Yeah.
Is there a reason for that, you think? More smoking, vaping, hookah, stuff like that?
Yeah, we're trying to learn. So what we've definitely learned is that there are other risk factors beyond that personal smoking history. So radon gas exposure is actually the second most common cause of lung cancer in the United States. Air pollution has been shown and proven now to trigger the development of lung cancer as well. PM 2.5, I know you guys have heard a lot about that as well too. There's rising rates of it. There's also cooking fumes, work exposures, you name it, even some genetic changes as well too. But it's an active area of research that I'm really passionate about.
Yeah, and that's why like in the ER we get like incidental findings, and
Yeah.
a lot of times the incidental findings, you get a chest X-ray and there's like a nodule there or something. You tell people to follow up on it. If you're like a member, just listening right now, like please follow up on it, because you don't want to be at another ER visit in 2 years for something different. They're like, oh, now it's definitely lung cancer.
Yeah.
This probably developed over the course of 6 months or a year, and if you'd follow up on that nodule, maybe the situation wouldn't be as bad as it is in that situation.
Sure.
Yeah.
100%, man.
Yeah. Any other thoughts on this clip? What I guess my question for you mentioned rounding. What's like the longest round, like during, could be anywhere, med student, resident, fellow, like in the ICU or something? Like,
It was definitely ICU rounds.
Yeah.
I think they just took forever. And where I trained, the intern that was on from overnight was the one that had to present all the patients in the morning.
oh, that's brutal.
And so it was brutal. Like you would be exhausted and you would have to give beautiful presentations, and it depended on the attending that was sort of grilling you a little bit to expand on your differential diagnosis. It's like, man, I just want to go home and sleep, right?
Yeah.
So those were rough.
That's kind of crazy, man.
Yeah.
You get off, you're there for 3 hours rounding, and you got to come back the next night.
yeah, like that leaves you like 7 hours of sleep, basically.
Yeah.
And
We would just sign out to the day team represent, like anything happen overnight. That would
Yeah.
be it, man. When I was in ICU, yeah.
We had one attending that was like that during my ICU, where we did the same thing. Like, oh, any new patients that came in overnight, the overnight person has to present.
exactly.
Okay,
right.
yeah, overnight new
Exactly
ones,
right.
yeah. We do those first, though, and let them leave afterwards, though. They wouldn't have to present the whole
Yeah, I
team,
think we
though,
definitely had a time where we were allowed to leave.
Yeah.
It usually happened, not always, right? But
Yeah.
by the end, we were just exhausted.
Yeah. That's, I really loved ICU, except for that part. And we were talking about this in a previous episode as well. Like the rounding, I just could not do. Because, like, I mean, obviously it's for teaching purposes.
Yeah.
So I get it. I'm not, like, hating on it. But, like, you have to do it if you're in that environment. So,
Yeah, we talk about like ER docs being really well rounded. I think ICU docs are some like the most knowledgeable people, man. Like,
They're
they're
so smart.
Yeah, like some of the most knowledgeable doctors, I think. Yeah.
Yeah, they're like one of the few where like I'm still, I wouldn't say intimidated, but I get my story straight before I call the ICU.
Yes.
Like the hospitalist, maybe I'm like, yeah, this is like an acute console surgery. They're not going to ask any other questions, clean, simple. But any ICU patient, I'm like, did I miss anything? I need to make sure I have everything.
That's so
in a
true.
row.
That's a universal experience.
Both parents work, but neither of them have health coverage?
Orlando and his wife have multiple part-time jobs that don't offer insurance.
Can they qualify for Medicaid?
Unfortunately, no, because their combined annual income is over the Medicaid threshold for a family of 5.
So they make too much money?
And not enough at the same time. They live over the poverty line, and yet they are still living paycheck to paycheck. I think their best option would be to buy private insurance through the Affordable Care Act.
I'm sorry, Anna.
How much will it cost to keep my dad in the hospital?
I don't know. But the ER visit alone will likely be in the thousands. We will figure something out, okay?
Yeah, it's just such a tough situation when it comes to this, and this is the reality for like millions of Americans. This isn't like an isolated thing where, you make a certain amount and you don't qualify for health insurance. You work a bunch of part-time jobs, so they don't provide health insurance. And then on the flip side, if you want to buy insurance in the marketplace, it's going to be insanely expensive.
Yeah.
I pay hundreds of dollars for like a high deductible plan, and I'm like a younger, healthy person. Yeah. Now, obviously, if you're not a young, healthy person, you've got diabetes, hypertension, you've got a history, buying something through the ACA for your family, that's going to be thousands of dollars a month. And at the same time, you're not, poor enough to afford Medicare. And so, we see patients like this all the time. And what happens is, they can't get their medications filled, or maybe they need to be admitted and they won't want to be admitted because that bill's going to cost them so much. And they're going to show up again tomorrow or the next day unconscious. And now the situation's even worse. And so it's just very tough, I think, for those of us that have health insurance or, it's provided by your job. You don't think of this.
Yeah.
And you think, and unfortunately, there's this kind of stereotype where, those that don't have health insurance, they don't have good jobs or they're not working. So the jobs aren't providing insurance. But you have like this situation where this guy's working like multiple jobs and they're just in this, they used to call it a donut hole. Where they're in this donut hole where you can't get health insurance. And like, I just think about that. I'm like, I'd like bang my head against the wall. I'd be like, what do I have to do to get like this thing that I feel is like a human right? But yeah, that's why I picked this, where it's, we think of a lot of times like the news will say, oh, this many million people are going to lose health insurance because of this bill. And you just see it as a number, but like that's like 17 million or 20 million, whatever that number is of these instances happening.
Yeah, we have what you said, like that gig economy, all these like little side gigs that brings in a lot of money, but they don't bring the traditional benefits in. It limits people from getting health care. And like you said, the Affordable Care Act, you can get stuff on the marketplace. I've never really went to it. I don't know how much it costs. I know there are some subsidies that are kind of going away, and they're raising premiums now. But it's an unfortunate situation. And it's like this guy's just working hard, his family's working hard, and they can't afford to get basic care. And it happens to a lot of people.
Yeah.
Yeah, no, I think what you said about how as physicians we don't really consider this side, like we don't learn it when we're in medical school, and I think maybe, and I hope that the curriculum is changing where we are exposed to more of this, where we challenge ourselves to really think behind not just the medical facts and the care that we're delivering, but truly how it's delivered, right? I think it's so important. And so I'm just speaking as an oncologist, cancer care is really expensive, right? Not only the drugs, but having access to all the specialists, having to go for the actual infusion appointments, it's a lot. And so in cancer care, we talk a lot about toxicity. And by toxicity, we're often very focused and anchored on the side effect profile. Nausea, vomiting, you're going to lose your hair, your blood counts, risk for fever, you name it. But there's also this whole other aspect of toxicity, financial toxicity, right? And I think this highlights that. And then also time toxicity. So, patients and their families have to spend a lot of time at cancer centers getting oncology care. And so I really like how this highlighted that aspect of toxicity beyond just the conventional side effects and symptoms that patients present with.
Yeah. One of the most, for me, helpless feelings in the ER is when I'm discharging a patient, they have no health insurance, and you say, hey, follow up with a cardiologist. You're ruled out for ACS. You're not in like a risk category where we have to keep you today, but follow up for anything. Yeah. And like I know deep down inside, they don't have insurance. And a lot of people have insurance, and they're like, the cardiologist won't take my insurance. There's like one cardiologist in Houston that'll take in the wait's like 4 months. There's those situations, and there's like no more helpless feeling than that of like, I know I'm like discharging this patient. I'm doing everything right by what the system expects of me, but like I know this patient isn't going to get the care that they need or the resources that they need, and that's the unfortunate reality of practicing medicine in 2026 and in the U.S. system.
Yeah, you talk about cardiology, man. I think more like ortho. A guy with like a broken bone, like, where are they going to get it repaired? Like, it doesn't need to be repaired right now. Like, this person may never get their hand fixed. They may be right-handed. They may have a job. They use their hands. Like, what are they going to do? You refer them to someone, they can't get in, don't have insurance. You need to pay a copay, you need to have insurance or pay out of pocket before you even get in to go see someone.
Yeah. For me, like, so like I think it's like a perfect example. My dad owned a business, right? So we were fine. Like we weren't like poor or anything. But once again, health insurance is like insanely expensive. Yep. Pre-ACA, so like pre-ACA, good luck getting independent health insurance. Like that's gonna be thousands of dollars a month. And so we didn't have healthcare insurance. And then the Affordable Care Act passed, and so we got health insurance. And like 2 years after that, my dad had like a medical emergency, and I'm like, thankfully he's okay today. But I think back to like, what if that medical emergency had happened before we had that insurance through the ACA? Like, God knows how that situation would have turned out. And so for me, it's just like, when we talk about like these millions of people, like you said, the big beautiful bill kicked off millions of people off those extended ACA subsidies. So because of that, they lost coverage, and then because of Medicaid as well, some of the cuts to that, lots of people are going to lose coverage. And so these are like human stories that are having to deal with this, and like this situation where later on in the clip, the teenage daughters, I call it, pick up extra shifts at the coffee shop, and you're like, they're trying everything, but like $100,000 bill, that coffee shop shift isn't going to help with that. So it's just brutal. Yeah, because
we only have like 2 city hospitals here in Houston, and those things get inundated like all over, and it just gets rough. There's only so much they can do, only so much they can, like, people they can see in the day, and so it just makes it hard.
Yeah. Well, I don't know about you two, but universal healthcare, please.
Yeah, man. We've looked into it. I mean, I've looked into like different countries, how they do different things. Everyone does it a little different. Why we can't figure it out, I'm not really sure.
Yeah, I mean, I think all of Europe's figured it out. Many other countries. I think like when it comes to cancer care, for example, we have the best care. I wouldn't want to be anywhere else. But like Pakistan, for example, right? Like I would, I'm from there. I've visited, every summer as a kid, loved the country, would not want to get healthcare there, right? Yeah. But the, kind of weird thing is they have universal healthcare, right? Wow. Now, like they don't have good quality healthcare, But like even countries like that, they have universal healthcare, and so it's just wild where like even we talk about like Europe and these developed nations having it, but even like developing nations, there's many that have universal healthcare because they see like, hey, any other system is just simply not going to work.
Because I hear people talking about like, okay, if you go to like Canada, for instance, like, oh, they have universal healthcare, but if I got to wait like 5 months to see a doctor, like my wife's from Canada, she's like, it doesn't take that long. Like maybe if you need like something like this stuff, it can take that long, but you can get in and see a doctor at a reasonable time. It doesn't take that amount of time as people think because you have universal healthcare.
Yeah, that's what I've heard too. Like honestly, recently over the last month, I talked to 2 Canadians, or one Canadian, one person from Norway, and said similar things. They're like, yeah, you're probably not gonna get an appointment for your like chronic knee pain tomorrow. It's probably gonna be like in 2 weeks, 3 weeks. And honestly, with how booked folks are here, that's how much it takes.
To where it is now.
Yeah, with what you have.
ENT doctors like 4 or 5 months out sometimes. Yeah.
So. Yeah, okay, well, hopefully, maybe next time we have this conversation, healthcare will be
Things will have changed, yeah.
What the fuck? He was stable.
Slight change in status.
Okay, get the clamp ready?
Who's the genius who pulled that out?
I thought it was a loose fragment.
Next time, leave the decisions to the adults.
Okay, ready to go? Whoa.
Ooh, looks like an icicle.
Christmas in July.
Hey, Sophie, can you answer that? Okay, I'm injecting the next step.
Hello?
What is that?
It's a syringe filled with tiny, rapid expanding hemostatic sponges.
Okay, got it, thanks. Radiology attending says a resident missed something. There's a radiopaque foreign body in the left paralumbar musculature.
Not anymore.
Sounds like first week in July syndrome.
Yeah, it's, again, I picked it because like the last like line he said as well, first week of July syndrome. A lot of people, I don't know if they know about that. Like most residencies, like all residencies, we start July 1st. This is the first week we start. It's not that bad. It's safe to go to the hospital in July. People always say, don't go to the hospital in July. At least for me in ER, like we are so overstaffed. We have a bunch of interns there. But we also have a bunch of second and third years, and people are watching over you. You're not just by yourself. And like you said, the resident missed something, but the attendants that are reading it, most of the time the attendant reads it, a little bit faster than that though, but the first week of July is something people talk about, but again, let people know it is safe to go there.
Yeah.
You're not just like a doctor, fresh doctor 1 week out of med school. He's not there running around doing things himself. He has someone overseeing them. And especially for me, man, like I was like, do I put orders in myself? Do I have to like make sure? But the first week I like ran stuff by everybody until I got a little bit more comfortable. But it's safe to go to the hospital first week of July.
And I feel like your attendings usually are way more vigilant during that first few months as well, because they know you don't know what you're doing. For those that maybe are not medicine, like you graduate medical school, but honestly, you do not know anything about medicine. You've just memorized a bunch of facts, essentially, is what you've done. And your journey of actually becoming a doctor starts on July 1st of whenever your first year in residency is.
For sure, because that guy, I forgot the med student's name. Super smart guy. He knows a lot. But he doesn't know. He's super smart. But it's kind of you are like because you're probably the smartest you're gonna be. It's like that in med school because once you get specialized in like ER, like in college, what you're doing, you start to forget other things. You get kind of like this tunnel vision of what you're used to. So that's probably the smartest you're gonna be. But again, like you don't really know how to function in a hospital that much.
Yeah.
Yeah, no, I agree with you guys. I think July is probably arguably maybe the safest time. Everyone's like double checking, triple checking. And everyone has this, they don't have that false sense of comfort as well, too. Like, I remember actually placing my first order as an intern, and it was Tylenol.
Yeah.
And I was like double, triple checking. I was like, is the dose right? So, like, I think everyone is actually hyper vigilant, if you will. I think, and I would argue it's maybe later in the year where you maybe need to be a little bit more nervous. But to my knowledge, I don't have any evidence to say, hey, listen, when you go to July and you go to an academic center that you're going to compromise your health outcomes. I don't think that's a thing.
Yeah. Honestly, I think the most difficult thing is like communication.
Yeah.
Like people, if it's a pager system, and yes, pagers are still used in hospitals. Like they don't know how to return a page, or whether it's an EMR messaging system, or how quickly things get done. Because like interns will get lost, right? It's like I'm going to see a consult on this floor. Like I took the wrong elevator. This one doesn't connect with that. So it's honestly the logistics that slow down more. But like in terms of patient care, that would feel totally fine.
My first day I had to do an LP, and like I didn't know where the kits were.
Yeah.
I was at a county hospital, so you basically had to do everything yourself. Get all your materials. I'm like running around trying to find a long needle, trying to find syringes, where do I get the lidocaine from? It was my first order was a Zofran, and I was like,
there you go.
I was like, do I put it in? Do I have to ask to put this in? Is it okay? Is it okay if I just order this?
Yeah, for me it was it definitely wasn't my first order, but like when I ordered morphine, I was like, oh man, am I sure I'm doing this?
Yeah.
Are they allergic to it? What's his blood pressure? Like going down the list of like things that could go south.
Oh yeah, man.
Yeah. What about I'm just curious and asking you more. Maybe you've seen it. Like where they inject the deal to like kind of cause hemostasis, where they the bleed. Have you seen anything like that? Like
It's mostly used in like combat and armies. I know they use it a lot, but I haven't seen it used in ER. Most of the time, what we do, EMS normally gets it first. They normally want to like get some stuff. But I know they use it like in combat and like in wars and stuff like that. But I've not seen it in the hospital yet.
Yeah.
I haven't either.
Yeah. I've heard about it, but I've never seen it personally. I'm like, man, it'd be cool to see like a bunch of bleeding, and you're like, oh, I'm going to stop it with this. Obviously, surgery's bedside, so it seems like more of a more than just something what an ER doc would do. But yeah, maybe like a combat medic situation. The other thing that I think this points out is usually when errors happen, and I think this is true for every field, but like in medicine too, is we've all heard of like the Swiss cheese model, where it's not just like one thing. So like in this case, they never rolled the patient over. And if they'd rolled the patient over, they would have seen that you don't need radiology for it. You would have seen a piece of glass stuck in the guy's back. And so there was like one error. And then the second error was like the radiology maybe on his first day missed this foreign body. And so those things compounded. And so I think they call it the Swiss cheese models because you put a bunch of pieces of cheese next to each other, and it's going to take like numerous things to go right or wrong in this case for that to happen. And so usually an error is not going to happen just based off like one thing being missed or whatnot. It's like literally like, oh man, 5 different things happened for this bad outcome to happen. So I thought that was interesting.
Yeah, OV, man. Over eager.
Yeah. What and that's the other kind of common thing in emergency medicine. Like someone comes in with like some type of foreign body or they've been stabbed and whatnot. And it just feels like the most like the human thing to like, oh, let me remove it. But you're like, nope, I can't do that because there's probably an artery under it or something that's going to get much, much worse. If I remove it, I have to call the surgeon for it.
Yeah, man. Yeah. It's a good clip.
Yeah. What do you think is going to happen season 2 onwards?
Oh man, I don't know. There's a lot to unpack there, right?
Yeah.
I think Langdon and then Dr. Robbie, that whole sort of dynamic. I'm interested to see how that plays out. Looks like they finally had to confront each other in a recent episode, so we'll see what happens. But I am excited to see just the further character development. Obviously, the rivalry that's happening between the medical students is also really interesting. Used to hate those gunners that were, your co-meds. I hope I wasn't the gunner. I don't know.
Yeah.
But it's just it brings you back to a time that feels like a while ago, still recent, but a while ago. And so seeing these things, having flashbacks, connecting with the show, just excited to have that happen.
Yeah.
Yep, sure. I don't know. I'm interested to see. I know we're kind of behind when we're filming. It's like, what was the reason of the hospital kind of like shut down? Like, what was the cause of it? They're still betting on that. Yeah. I think we talked about what possibly could be. Yeah.
They showed in one of the promos. And I'm just waiting for the July 4th chaos, man. Like, who's going to show up with their hand blown off?
Yeah, there you go.
Like, that's got to be a part of it.
Yeah, because it's so early in the day, right?
Yeah.
So we're still waiting to see.
Yeah, like it hasn't. It's not even night yet.
Yeah.
What is it, like 12 o'clock? Or
I think 11 a.m. 12.
Yeah.
Yeah. What are your thoughts? I'd be particularly interested to hear your thoughts on Giovanni being a low key influencer. I think that happened this episode of Pearson. Yeah, you're like, oh, that came out of nowhere.
That is wild. Yeah, I had a feeling because they kept saying Dr. J, and I was like, who else is there besides her?
Yeah.
But I think that speaks to the power of how patients are learning about updates in medicine and who they're trusting, where they're going, right?
Yeah.
And that's, I've actually done a study where we've looked at those patients with lung cancer specifically. Where are they going? Are they using online sources to learn more about their diagnosis, learn more about their treatment options? And the answer is yes. Over 90% of the patients that we actually surveyed had gone online before even their first oncology visit. And so I think that speaks to the power of social media, but also you have to be really careful with what you're digesting, what you're seeing. Again, misinformation, disinformation, trying to dilute that with credible sources like you, and hopefully you one day on social media too.
Maybe.
Yeah.
Because the information's out there, man. But like you said, you got to just make sure you're getting it from the right source.
Yeah.
You can't just be relying on ChatGPT and Gemini too as well.
Yeah.
To use those, you got to make sure you're getting it, asking the right questions, and getting it from the right source.
Yeah, and I think it's perfect where like in maybe we should have just picked it as a clip, but like the patient keeps asking for her, saying she's like the best doctor in the entire city when she's like a resident or a med student. And that's the power of social media, because there's unfortunately like people like yourself that put out good information that I would like, hopefully I don't have to deal with a cancer situation, but if I do, I'd be like, you're gonna be my first call. Like if I was a patient, I would want to come to you. But at the same time, there's grifters out there that are also really good at communication. And they are fooling people and gaining trust of people in the same way that people like you are. And so you may fall for some type of supplement or some type of like homeopathic cure for, you know, some type of issue they have, like diabetes or cancer and whatnot. And so as good as it can be also just as bad, which is the scary part.
Yeah, I like the way Linda had. He didn't make her feel bad for like being an influencer. Do people ever give you like a hard time like that at work about influencers?
Oh,
like,
yeah.
Do people at work comment on your stuff sometimes or say things?
Yeah, I mean, I've definitely had comments like, is this the best use of your time, right? Are you sure this is what you should be doing? My answer to that is if you can make the difference, like a true difference in even just one person's experience or feeling empowered or having true knowledge about how they're going through their cancer care journey, that's all I needed, to be honest. And I don't know if I like the term influencer. You can say educator, you can say many other terms. I mean, of course, influencer is a really powerful one, but I don't know. I just think it's honestly truly an extension of what we do all day, every day as physicians, and that's being educators. We can do it with an online presence. We can adapt and adopt to what and how patients are learning today, right? And that's with digital tools.
I agree because I'm thinking about it right now because like I don't know how many patients you see in a day. Like we see maybe 2 per hour, we see 20 patients in a day. Being a educator online, you have the potential to see thousands, hundreds, and influence them as opposed to just touching 20 lives in one day.
Like you, I hate the term influencer. Unfortunately, it's like the quickest way to kind of relate to people like what you do online is. But educator is a perfect word.
We call it medfluencer. What do you have? Medfluence? What's another term for it?
Medfluencers, yeah. Well, Medfluencers is a company, but I mean it should be Medfluencers. Shout out to Medfluencers.
Yeah, exactly.
We love our Medfluencers family. Awesome. Well, where can people find you?
So you can find me online at Doc. I'm on TikTok, X, and on Instagram.
Awesome. And your podcasts, those are through larger organizations, medical organizations?
Yeah. So the podcast that I host and co-host with my colleagues, it's Lung Cancer RX. So you can find it on Spotify. You can also find it online.
Wonderful. Well, thanks so much for joining us. This was awesome. This was fun.
Yeah, thanks for having me. Excited to finally meet you.
Appreciate it. Thank you for coming by. We really appreciate it.
Of course.
Awesome. Till next time, folks.
Thank you.